Hi, I'm Dr. Liz Perkins. It's my pleasure to do this talk for AAIDD. I'm a present member of the board and been a member of the association. You might notice from my accent, I am not from the United States. I am from England originally. And I'll talk a little bit about my experiences and my work regarding health advocacy, aging, and the needs and quality of life of aging caregivers. I actually came into the field because of the issue of stigma surrounding people with disabilities in employment settings. I applied to be a registered nurse in the UK, and actually my very first interview was asked, well, who dresses you on a morning? And so it was really quite disturbing that the health profession would have a view of persons with disabilities. I'd worked in nursing homes. It wasn't like I had no experience whatsoever. And then the next question that was asked of me was, oh, well, you can't do CPR. So the interesting story behind this is that at the time when I was refused, basically I had a letter saying thanks but no thanks. We can't allow somebody with a disability to train as a nurse with a congenital amputation. I was born without my right arm. I saw an advert for nurses to train in the field of intellectual and developmental disabilities over in the UK. We have a specialist nursing in that field. And so I sort of persistence made me go to there and ask them. I wrote them a letter and said, give me a chance, I'll prove that I can do this. And their approach was, well, we don't know. This is something very different to me, to the nurse tutor. And so she said, we'll employ you and as a nursing assistant and put you through your paces and see whether we think that you would be able to do this. And after the end of the first week, they said, you're in. We're going to accept you into the training. And that was my real first experience of people with disabilities and the disability field in terms of first of all, the stigma, and then also the fact that people in the field provide the supports and provide the opportunities and the risks. We all learn from risks, taking chances and making mistakes. And people with disabilities are often denied that right to make a mistake and learn from the mistakes. And so this was a joy to me to sort of be recognised as such. And I trained, I qualified, I became one of the first nurses with this disability. And hopefully there's been other people I know in the United States that have come. So that being said, I also had a nephew. Again, it was after I trained in the field. I have a nephew with autism, so I'm very attuned to the needs of families and family caregivers, and so this is where my work sort of intersects. I do work with health advocacy. I designed a document called My Health Passport, which is probably one of the proudest things that I've done, and as a way to ensure people have a way to empower and tell health professionals what their supports are. One of my mantras is to make the unfamiliar familiar, and a lot of healthcare professionals don't get training with the needs and the supports that people with disabilities need. And so part of my work is educating health professionals, and that's across the whole spectrum of people in terms of allied health professionals, medical students, nurses and physicians that have trained but never really had any experience or knowledge of people with disabilities. And and this health advocacy works both ways, and so it's a case of training the health professionals, but also training and actually empowering individuals themselves to be more forthright about their needs and rights and what supports they need in health. So another area of mine is the issues of aging caregivers, and caregivers obviously more attuned to that as my nephew has grown older, and we sort of think about what the future holds. for him, and it's the same for many caregivers that have been lifelong caregivers. And so one of the things that I'm really interested in is not just the fact that these lifelong caregivers have been supporting individuals with intellectual and developmental disabilities across their lifespan, but now they're having caregiving duties for other family members. And so it's a bit of a different situation from caregiving that we sort of think about in terms of, I call people in this situation compound caregivers, because they have been lifelong caregiving for their son or daughter, and then they have additional caregiving responsibilities. And you know, that can be obviously quite stressful. And also, as you've been a lifelong caregiver, typically you've had support from individuals in your family that have helped in your primary caregiving role. And as you're getting older, those individuals that might have been assistants to that, your spouse, your parents, who were the grandparents of the person with an intellectual or developmental disability, are indeed become care recipients of care rather than caregivers, or assist you in your caregiving role. And so that obviously is puts those caregivers into a situation where not only they're having additional caregiving responsibility, but they're caregiving for other people that used to support them in their caregiving role. And so that network of assistance swaps over to being an additional support needs that they need to provide. And then also, you know, they have a smaller support network that they can call upon, because that very person becomes an additional care responsibility to the person. So in terms of how we support folks as people age, we have to think about not only these aging caregivers, but also the individuals. And one of the things we hear a lot about in the field is about the transition from children into adult services. And one of my particular concerns is, you know, the other end of that lifespan, the transition of these individuals that might have lived with their parents, and then might mean needing to be you know, a transition in terms of retirement, of where they're working, a transition in terms of they might be moved or go to a different place of residence, and those transitions might occur in a very abrupt way, with not as much planning as we would like to see. And also there's a lot of individuals that I'm concerned about, that there might be a vulnerable population out there that have never accessed services, that might have mild support needs, but as they're getting older, and some of my research has found this, the reciprocity, obviously it's great to have with the caregiver and the care recipient, that you have a reciprocity of their support. But what we're seeing is also a reciprocity that actually might turn into co-dependence, and then might actually work for the individual with developmental disabilities to become the caregiver rather than the care recipient. For example, one lady I interviewed as part of my research was 94, had a son that was 52 with Down syndrome. The lady, she had advanced macular degeneration, and she freely admitted, you know, I need my son to support me, not the other way around. So there's this population, I think, that's flying under the radar that might not be known to services, that I think is of great concern to me. So that's one of the reasons why this area of caregivers and transition as folks are aging is an issue. And then the issue of aging with intellectual and developmental disabilities. There's been a huge increase in life expectancy in the last 30-40 years. Holistic care has obviously contributed to that. But what we do know is, you know, with this increased life expectancy, There's individuals that are now having to face aging-related chronic illnesses that we in the general population see. So cardiovascular diseases, osteoporosis, things such as osteoarthritis, cancer. The number one risk factor for most cancers is increasing age. So that prevention and health is very important across the lifespan, particularly in a population that has significant challenges in terms of that they might have multiple other issues. For example, people with cerebral palsy, only 40% of people with cerebral palsy have cerebral palsy. 60% have another developmental disability, be that intellectual disability, be that being deaf or hard of hearing, be that having epilepsy. So that makes it very complex. And so you have people that have these lifelong medical issues, and then the onset of aging issues, which can be very complex. And one of the issues that I really, again, want to make folks a lot more aware of in the field and beyond the field in the general health setting is that we don't really have the healthcare providers with the knowledge of aging issues in this population. Many people that do have any type of training, pediatrics, it's in the pediatrics, it's in the young children to young adults, and not the older adults. So we really need to do something, flag waving for people about, hey, there's a whole population, and there's a lot more of the population that are adults and older adults than there are children. And so I think we need to really look at the balance of how we provide care across the lifespan. And I think that's pretty much what I wanted to say and share with everybody today. I'm really, very passionate about making sure with healthcare advocacy that we need to reach out to all different types of allied healthcare professionals. It's not just the doctors, it's not just the nurses. And then also in terms of aging services, we need to make sure that people are trained about the issues of individuals with intellectual and developmental disability. They will need additional supports, but that doesn't mean to say that they can't successfully age the same as you or I can. And again, it's just to be mindful of these transitions that can take place in time.